Thank you. Before I proceed, just to deal with some housekeeping, the webinar is due to run for an hour and a half. There should be time for panelists to consider your questions and comments, so please put them into the Q&A box, which you should be able to find at the bottom of your screen. I must also acknowledge and praise the considerable work of my colleague Christopher Johnson in organising this webinar and its stellar lineup of participants before we proceed at all. So turning to the issues, what are they? COVID is having a disproportionate and devastating impact on ethnic minority communities. Many reports have highlighted that fact from early April 2020. The Office for National Statistics and its most recent stats released on Tuesday of this week show that in the first wave, all ethnic minority groups had a higher risk of death than the white British population. Black men and women were approximately 4 times more likely to die. And in the second wave, the risk of death in South Asian populations remained up to a staggering 4.8 times higher than the white British population. The government has been criticised for being slow to acknowledge the higher rate of BAME deaths through COVID, whether of patients or frontline workers, or to devise and implement appropriate measures in response and to prevent severe and disproportionate impacts in repeated waves of the disease. Public Health England, since disbanded, finally reported in June 2020. It simply confirmed the higher risk of mortality and that the unequal impact of COVID may be explained by a number of factors ranging from social and economic inequalities, racism, discrimination and stigma, occupational risk and inequalities in the prevalence of conditions that increase the severity of disease such as obesity, diabetes and asthma. This report failed to produce major new insights into why these disparities were occurring or to recommend a plan of action to save lives. It said no more than was already well known. COVID did not create health inequalities, but rather exposed and exacerbated long-standing inequalities. It has taken a pandemic and the deaths of a great many people to put the issue of BAME health at the top of the agenda finally. There have been 2 key reports considering causes and solutions. The first by Baroness Doreen Lawrence, one of our panelists. It's called Unavoidable Crisis. And the second is by the Women and Equalities Committee of the House of Commons. And that was published in December 2020. And the government's response is due this coming Monday on the 15th of February, which makes this a very timely event indeed. So with that brief introduction to the issues we're going to consider tonight, I'm going to hand over to David Lammy, who needs little introduction, but I am going to mention a few of his career highlights. He was the first Black Briton to attend Harvard Law School. In 2000, aged 27, he became the youngest or the then youngest MP representing Tottenham. He held ministerial portfolios in the Blair and Brown governments, and as an opposition backbencher has a reputation as one of Parliament's most successful campaigning MPs, involving himself in cases affecting his constituents such as Victoria Clambier, Baby P and Mark Duggan. His talents and commitments are recognised across the political spectrum. He was appointed by David Cameron, then Prime Minister, to lead an independent review into the treatment of BAME people in the criminal justice system. The Lammy Review, still, which was published in 2017, still is used to guide government policy. He was awarded the title of Campaigner of the Year in 2018 by The Spectator magazine, and he's currently Shadow Secretary of State for Justice and Shadow Lord Chancellor. And I'd like to welcome David Lammy, MP. Thank you. Over to you.
Thank you very much, Sani, for that wonderful introduction. I could speak for hours on this subject, as you would imagine, but we have a great list of panelists this evening, and thank you so much for all of you that are participating, because this is a record number. It's wonderful that over 265 people I can see are giving up their Thursday evening. This is a somber subject. It's a subject that cuts to the heart of racial inequality in our country, all revealed very, very bare. What are the jobs that Black, Asian and minority ethnic people do in the UK? What's the face of that community? What are the sacrifices they make? Where do they work? And why is it that such persistent and pernicious inequalities exist right across the community? and we've got a range of speakers. I will introduce each at the beginning. They'll say, speak for 5 or 10 minutes, and then I want to get to and allow good time for the Q&A. So I will send in the chat if speakers go over that allocated time. But let us begin with Intisar Chowdhury, who's just 19, and the son of the late Dr. Abdul Chowdhury, and his open letter to the Prime Minister about PPE at the beginning of this crisis sent those initial alarm bells, really, about the reality of the workforce in the NHS and what they were experiencing. It cut to the heart of those initial images of the first few people that were dying in those first 100 days or so, and the face of those people. And the face of those people was a black and brown face. It was the face of the modern NHS. And so we're very grateful that Intisar is with us and is prepared to share at a time which must have been very, very hard. I hand over to you.
Thank you so much. And thank you so much for having me as part of this talk. I'm really honored to be speaking alongside so many accomplished and distinguished people, speaking from a wide variety of experiences. I was really pleasantly surprised to be invited to speak as part of this amazing event. So thank you so much for having me here. So as Mr. Lamy said, I am the son of the late Dr. Abdul Mahbub Chowdhury. So that was my father. He was a consultant urological surgeon. He was 53 when he passed away from COVID-19, and I'd say it was nearer to the beginning when people weren't really aware of the severity of the situation, the severity of the pandemic. It was what feels like a different world, to be honest. I mean, right now we're in this kind of ongoing state of worrying about what the next piece of bad news is going to be. But when my father died, it was more towards the beginning, where we were just starting to see what was to come. My father wasn't actually a frontline worker, but many of his colleagues were. He worked at Homerton Hospital in East London, and he saw that there was an injustice going on within his own hospital, that injustice being that his colleagues, everyone that was working on the front line, whether they be doctors, nurses, cleaners, all types of workers within a hospital, they weren't being adequately protected. And my father wanted to speak up about that. He wanted to find a way to change that, and change that he did change that maybe after his passing, but he changed it nonetheless. He wrote a letter to the Prime Minister, an open letter on social media. He addressed the Prime Minister and asked him, or pleaded him, to provide NHS health and social care workers with adequate PPE, or at least a lot more PPE than they were getting at the moment back then. And this letter that he wrote, he poured his heart out into it. I remember reading it, actually. I read the letter after my father passed away, because at the time when he wrote it, my father was actually suffering from COVID. The symptoms, he was suffering for the first time. He was sitting in his living room, isolated from the rest of my family, which was pretty difficult for me and my sister and my mother. And at the time, we didn't really understand that this was potentially the last few days that he'd be spending in our house before going to hospital. And while he was isolated in our living room, he wrote that letter from his phone, just typing it, in a state where he was struggling so much himself. He decided, no, I'm going to do something about everyone else, which is actually a recurring theme of my father, to put everyone else before himself. And I mean, that was just the type of person that my father was. He wrote that letter, and it had an impact. After my father passed away, the media emphasized this letter he wrote, everyone started to find out about this letter that he wrote. I found out about it for the first time, and we started to see a change. My father, among many other healthcare workers, had pleaded for PPE, had suffered as a result of a lack of PPE, and all of this started to bring about a change. I guess my regret would be that my father's concern was only taken seriously after his death. If he had been listened to before, if, you know, the government and others had taken his concerns seriously before, the concerns of him and so many other people, then perhaps we might have seen a difference back then rather than a lot later. But what's done is done, and we cannot change that. And I'm just grateful, so grateful that there was a change afterwards. My father raised concerns. So many doctors, nurses, healthcare workers raised concerns. There was a huge movement, and I'm really happy that the pain that my family and I went through, at least even if it's one family that's been spared as a result of more PPE, if one family doesn't have to go through the same pain that my family and I went through, then I know my dad has done the job well accomplished. But unfortunately, that's not the case. We're seeing the death rates, they're getting higher and higher. There's still this disproportionate impact of COVID-19 on the Black, Asian, minority ethnic population. So many families are being affected. I am just one of many people left behind by their loved ones. And that might continue unless we take action. Right now, we're incredibly fortunate to have these vaccines that have been starting to go around. But obviously, one issue with vaccines is that there is a lot of uncertainty around them. There is a lot of worry around them, especially in the Black, Asian, minority ethnic community. Speaking from a South Asian perspective, I know there is a lot of worries about the vaccine in the South Asian community, whether that be out of fear, out of skepticism. There are a lot of worries. And one thing I saw actually, I think yesterday or the day before, I saw on BBC News or BBC Asian Network, I think, compiled it. They compiled a series of videos in all different languages, in South Asian languages, that were directed to perhaps the elder generation or first generation immigrants who perhaps don't speak English as well as their mother tongue. And these videos kind of broke down the conspiracies around vaccines, all of those issues. And I think really instilled the importance of taking this vaccine when offered. And I think that is such an important step to take to increase accessibility to healthcare, to address healthcare inequality. I think doing things like those, making communication a lot more easier, taking those steps makes it so much better, and really, you know, will hopefully increase the vaccine uptake by the Black, Asian, minority ethnic population. But as Sweeney said before about how COVID-19 has exposed healthcare inequality rather than caused it, I think that is an incredible point that she's made. The report that the government released following the concerns about the Black, Asian, minority ethnic impact contained, I think, I remember I read it when it first came out, and it talked about in one line how a cause for the higher cases of COVID-19 in South Asian communities might be due to overcrowded households. And I remember reading that and thinking, this is an official government document, and they have verbatim said that South Asians are more likely to suffer to COVID-19 because they live in overcrowded households, which I thought was honestly a bit of a generalization. I think because my father did not die because we live in an overcrowded household, and I have many South Asian family, Bangladeshi family in the UK, many of whom do not live in overcrowded households. So I think to see a generalization like that made in a government document was a bit disappointing. And obviously that report was, as mentioned before, not very insightful at all. And I'm glad that that was addressed. So it has been almost a year since my father passed away. And, you know, I think coming up to April, which is when my father passed away, a lot of, you know, flashbacks are coming up, especially because I'm seeing so many more stories of people passing away. And throughout this year, there have been so many especially Black, Asian, minority, ethnic tragedies that have happened, not just in the COVID-19, not just from a COVID-19 perspective, but just in general. We saw these huge movements taking place last summer, I think it was, the Black Lives Matter movement. We saw the case of Belly Mujinga, unfortunately, which is such a tragedy. The lady who was spat on by someone who was suffering from coronavirus and who then passed away from that. I think that was such a huge tragedy. She was a Black lady, and things like that, I think, things that stem from racism and then intersect with COVID-19 that led things like that led to her death are just, you know, I really can't put it into words. It just really makes me upset. I know that is not the best way to describe it, but I really don't know how those tragedies can be described. And I mean, yeah, we're here a year later. Things, I think, right now are starting to look slightly better than a bit before, because the deaths were increasing a lot, you know, over 100,000. And now I think the infection rate is slowing down. And I hope this means that in the future, everyone, especially Black, Asian, minority, ethnic families, will start to find some peace, especially those who have lost loved ones, a lot of them. Yes, I think, you know, I had so much planned to articulately say, but I think speaking about all of this is just bringing up so many flashbacks and so many memories that it just really is hard to find the words to say what I do want to say. But the essence of it is that, you know, everyone is suffering from this horrible, horrible disease. Minorities are suffering from this horrible, horrible disease. When racism intersects with COVID-19, that leads to a whole other level of problems. But having these conversations, talking about solutions and strategies and ways to address inequality in all aspects of society is how we move forward. And that is why this whole event has been set up, and I'm incredibly honored to be a part of it.
Linda, thank you so much for sharing with us. I've just got one question, which is, you know, many people listening, like me, my mother was a frontline worker, will understand the context for Black and minority ethnic people working on the front line in so many ways. And that is that they really put the time in, they really put the effort in, they really, because they feel that people are looking at them. Judgment can be tough. Holding on to your job, getting a promotion. And I just wondered if you have any sense of, you know, I'm quite sure your father was just tireless. And, you know, when I looked at that face of those NHS workers, I sort of felt I knew these people. And I just wondered if you had a sense of that in the weeks before he got ill.
I mean, so if you see the collage of NHS workers, health and social care workers that have passed away, I think, as you said, behind every single picture, you can kind of feel the hard work that each of them put in, the tirelessness, the work ethic, the compassion, the motivation to put as much as they could. And you could see that in every single picture of every single person that passed away, a lot of whom were Black and Asian minority ethnic people. My father, like many other healthcare workers, was a very, very hardworking person. I am not sure if that was because he felt that he had to do that, because he felt he was constantly being judged. That may have been a part of it, but I think it's inherent within everyone that comes to this country who does want to make a difference. I think it's something inherent that they want to give back as much as they can, because they've been given this amazing opportunity to work in this environment. They want to give as much as they possibly can. I think that's something that is common among every minority worker, every immigrant worker. And I think that is the explanation for why they work as hard as they do, and why you can feel that hard work after they passed away. You can kind of just see what they've left behind in a way, as in all the amazing things that they've done and their legacies. And yeah, that is something that's very common among Black and Asian minority ethnic workers.
Thank you. Put yourself on mute. I'm now going to turn to Dr. Sunil Darsan, who is a consultant in emergency medicine at St George's Hospital here in London, is very distinguished in urgent and emergency care. Very, very grateful that you've joined us, Dr. Darsan.
Thank you, David. And thank you, Intisar, for your presentation and your comments about your father. I find that quite moving, in that as the whole pandemic's been quite moving, really. And I just wanted to give my observations about my reflections of the pandemic so far. So it was around the same time as Dr. Chowdhury contracted COVID that I contracted COVID as well. And I was in hospital for 10 days. I just avoided intensive care, and then thankfully improved and was able to get home. It was only after that time that it became apparent to me that there was this disproportionate impact on healthcare workers, and it was being reported in particular about the impact on Black populations in the US, and that came into my field of view. It made me feel incredibly fortunate that I'd got through relatively unscathed, but even in the ward next to me, there were individuals of a similar age, similar ethnicity, who got worse and deteriorated. So that was quite very sobering indeed. I think that was in the first wave. Following on from the first wave, when I was back at work, I think that was the time when the risk assessments were being carried out with healthcare staff in relation to PPE. And although it was being conducted as it was, I did get the feeling that it became a means of potentially singling out individuals because of their ethnicity. And rather than going down the line, which I would have thought would have been more appropriate, of assessing risk and then upscaling PPE for those individuals at higher risk, who could then continue to work in their existing roles using their existing skills, it seemed to be working in a different way to actually restrict individuals in lower risk areas, so they weren't able to utilize their skills to the full. So to me, that appeared counterintuitive at a time when we needed our staff to actually utilize their skills to the full during the pandemic, rather than to sideline or marginalize staff. I think my third and deepest reflections have been obviously on the impacts of COVID on patients, particularly during the second wave. We know that 30 to 50% of the admissions to hospital during the second wave are patients who are Black, Asian or minority ethnic. I've seen a lot of patients present very late on in the illness. I've seen patients who only come to our attention when they're critically unwell. And some are in such extreme states that they're close to death when they get to us. This makes me question, as a healthcare professional, it makes me question whether we are doing enough to ensure that services are accessible for all patients. And not only does this apply to patients of colour, but it's also to older patients, patients with other vulnerabilities. Are we making our services accessible to these patients so that should they have an urgent or an emergency healthcare need, they know they can attend and they will get the care that they need in a timely manner. I think the one thing that has brought that into question to some extent during the initial stages of the pandemic was potentially some judgments being made by healthcare professionals leading to incorrect decisions, and then that impacting on patient care. One example was the use of do not attempt resuscitation decisions in the early stages of the pandemic, and that being made in blanket fashion in some instances, and that being done without the knowledge of patients or families. And I think elements like that really do knock the trust in the health system and in the health service. For patients, for families, and also for staff to have confidence in the system, there needs to be an assurance that judgments are not going to be made and that clinical decisions are made based on no form of assumption or bias, particularly in relation to urgent and emergency care, when these are time-critical decisions. And sometimes we may have limited information from family, friends, relatives, and therefore we just have a patient in front of us who may not be able to advocate for themselves because of the severity of their illness. And certainly I need to be assured, and we need to be assured, that no biases or assumptions are being utilised in those decisions for patient care. I suppose locally we've taken this forward in a very small way by doing training for staff, and I know it's a bit of a cliche, but training for staff, but really just trying to make them understand the impact that they can have on patients just by how they approach a situation. That may directly affect the information that a patient divulges, and that may then influence how accurate we are with the diagnosis and how accurate we are in terms of optimizing the treatment for that patient. We need to take a more sensitive approach to communicating with patients across cultures to allay fears and to diffuse tensions. And really, I want us to see a more nuanced approach, really, so that, because I do believe that that will lead to more positive outcomes in terms of patient care. Our very early evaluation of our training does show a positive impact on confidence amongst the staff. It does show a lower baseline knowledge amongst doctors, which is interesting, particularly around the issues of anti-racism and allyship. So I think that's something we need to focus on and think about how we can improve that level of understanding. As Intisar said, I think we have seen the impact of a more nuanced approach in relation to the vaccination programme and the uptake from communities by having that more personalised and individualised approach. But there's certainly more progress that needs to be made. Just to summarise, I think, undoubtedly there has been a disproportionate impact on people of colour during the pandemic. From my perspective, it's not only been noticeable in the numbers of patients attending, but even in those patients that we see who do things in a culturally sensitive way. We optimise treatment. We do the absolute best. And there have been many patients who, a few days down the line, reviewing their notes, you just realise they've deteriorated and passed away. So I'm not entirely sure why this is, why this disproportionate impact is on people of colour. It may be time before we fully understand why. However, I do hope that this will change our approach in healthcare, that we will have a more nuanced and more sensitive and a more outcome-focused approach. And I hope that becomes the norm in the future.
Sunil, thank you very much for that. Two questions. Obviously, the presenting late is worrying. And I wonder if you could say a bit more about what lies behind that, because of course, this will be an issue across a whole multitude of diseases and issues that people experience. And so there's something about not just accessing services, but how those services are relevant and front facing to these communities and where these communities find themselves really. And how, you know, given that we're all taxpayers, we all fund the National Health Service, how it could be that it's taken us till 2021 to really determine the extent of this inequality. And the second issue, and it's been an issue, it's not really been an issue in the newspapers, but it's definitely been an issue on so many WhatsApp groups, is this issue of equity and decisions made about who gets resuscitated and who doesn't. And frankly, Black, Asian and minority ethnic communities hearing stories that their loved ones have found themselves on the wrong end of those decisions. And of course, one of the issues here is families have not been able to be in the hospital in the same way. That in communities where English is not a first language, or you have not been educated to a, you know, in higher education. I remember the way in which when my mother was dying of cancer, I had to navigate for her through the health system. I had a lot of, you know, potential power in order to do that, but people were struggling from that. So it's very hard to hear decisions have been made that lacked equity. So I just wondered if you'd come back to that as well.
Yeah, I think on the issue of access, I think there has been a bit of a one-size-fits-all approach in terms of encouraging access, and it's only now that we're seeing that actually just a little bit of additional effort or a bit of a nuanced approach, a different perspective is all it takes to make people feel included and welcomed and know that the services are there for them. It has taken a long time. I think we've just so much in the past relied on this is what the message that we're going to give out, and it's the mainstream message, and those who access it, great, and those who don't, well, that's a shame. I think, you know, hopefully that's why I want to see that in medical training, in the design of services, in training for all healthcare workers, that there is a bit of an emphasis on a modulated approach to tailor it to the individual in front of you. And I think that will then, and you know, communities do get information, yes, through the media, but through word of mouth. And through word of mouth, that's how you build confidence amongst communities in services that are meant to be there for them. In terms of the issue around difficult decisions around resuscitation, etc., I think, I mean, I do not in any way, shape or form want to undermine or underestimate the difficulty of these decisions in the emergency and critical care environments. These are difficult decisions, and they are best made with due consideration, with focused purely on the individual at hand. I think the difficulty is when those individuals can't advocate for themselves, and there are no family around who can advocate for them. And so whether that needs to be, there needs to be a system of advocacy within hospitals that is there on the front line. I think there is, and there are recommendations, for instance, in the Ockenden review for maternity services, for advocacy services for women, And I think we may need to go down a similar route just to make sure that, judgments aren't being made inappropriately and unacceptably on all vulnerable groups who can't advocate for themselves.
Thank you very much. If you just go on mute, I'll turn now to Angela Sani, journalist and broadcaster, been involved in many programs on the BBC, has written for The New Scientist, Sunday Times, National Geographic, and her latest book, Superior, The Return of Race Science, is an excellent book. I've got it. I recommend to you. Now, Angela, there's been a lot said about the genetics of Black, Asian and minority ethnic people within this. I'm looking forward to what you've got to say. There's a second point, which again does not get sufficient comment, but obviously lots of people who come here are coming from developing countries. And certainly it's the case that if you look across quite a lot of those developing countries, the rates of death are nothing like what we're seeing here in the UK or say in the US. So I'm looking forward to your contribution.
Thank you so much. It's a pleasure to be here. It's an honor. And I'll try and keep it brief because I'm sure everybody wants to hear from Baroness Lawrence as quickly as possible. But there were two things that stood out for me in my personal life just before the pandemic, just before the lockdown started in the UK. The first of those was that in February 2020, the British Medical Journal released a special issue on race and medicine. And one of their findings was that, of course, there is racism in the NHS, not only directed towards staff, but also directed towards patients. And it's not well understood. And we need to kind of explore the effects of that. One of the last things, the second thing is, one of the last things I did before we went into lockdown was I was giving a lecture at the Royal College of Obstetricians and Gynecologists for a special event that was happening around Black maternal mortality, because we know that Black women face much higher risk of death when they're pregnant and when they have children in this country than other women, and other minorities also face a slightly increased risk. And we have tried very hard, many people have tried very hard, including myself, to claw back this narrative, this damaging essentialist false narrative that Black women's bodies are somehow to blame for that. It's been difficult because these ideas still persist within the sciences. They still persist definitely in the wider public, this idea that we are just different deep down, and that's what causes the stuff that we see. But we were clawing back that narrative, and certainly at that conference there was a wide understanding that the reasons for the differences that we see are because people are not getting the same levels of care. They're not listened in the same way. They're not accessing healthcare in the same way. And we can see evidence of that in the fact that the wonderful midwife, Jenny Joseph, who is trained in the UK but now works in Florida, has improved maternal mortality rates among minorities in the US, where she works, simply by improving the quality of care. So we know that that's possible, and we know that that's a dynamic that's playing out. So imagine my surprise and shock then that in March and April, when these statistics started coming out about minorities in the UK and in the US facing higher rates of death and higher rates of critical illness, that prominent physicians and prominent medical researchers in this country started speculating about the possibility of a genetic basis for that. And this was quite widespread. If anyone wants to go to the Science Media Centre website, where they were collecting comments from prominent researchers at that time, you can see this speculation happening. And I was shocked because there have always been racial disparities in health, particularly in the US, where at that time in March last year, we were seeing some of the biggest gaps. In the US, Black Americans die of almost everything at greater rates than white Americans. The life expectancy of Black Americans is lower than white Americans. So why would you not expect that same dynamic to play out in the event of a pandemic? It again was very difficult to claw back that narrative, to remind people, as the BMJ did in February, that we need to look at the social determinants of health. The reason that we see these gaps that we see, wherever we see them, whether we see them around race or class or geography or wherever, is down to a complex interplay of factors, not least demographics. I mean, let's remember that the virus hit London first, and London is a minority white British city. So of course the rates are going to be skewed on that front. Frontline workers, we know, NHS workers, we know, are disproportionately coming from ethnic minority backgrounds. We know, like I said, because of the BMJ special issue in February, that there is racism in healthcare and the way that people access healthcare. We also know that there are differences in underlying conditions, underlying health, because race overlaps so heavily with poverty in so many parts of the country. And in fact, a friend of mine, Pete Roble, who has been a sub-editor on lots of prestigious science publications in his career, he's retired now, but during the whole of last spring and summer, me and him were looking at the Public Health England data, and we were looking at how the rates were changing. And what we saw is that yes, rates were very high for ethnic minorities at the beginning. As the virus started to move out of London, they dipped a little bit, and we saw higher rates then in places like South Wales and the Northeast, which very white areas, but with very high rates of poverty. And I think that's the important thing to remember here, that it is not useful to think about any aspect of healthcare, particularly in a pandemic, along one axis. What we have to understand is all the different factors that come together to give an individual person their heightened risk, whatever they are. They can be, like I said, demographic, socioeconomic, to do with diet, to do with life history, the kind of job that someone does. Racism, structural racism is a factor here as well as structural classism is a factor here as well. So what we don't have, and this is again coming back to the BMJ special issue, they put out a call when they were writing up that issue for data, for research on racism in health. And I could add to that social determinants in health. We do not have that research, and we need it. They have it in the US. So just in late 2019, I was speaking at the National Institutes of Health in the US, and over there, the situation is completely different. Completely different. The narratives around this are completely different, and that work is being done. So what we need to do in Britain is catch up to that. We need to have the data, the information, and the statistics around the social determinants of healthcare and design healthcare around that.
Angela, thank you so much for that. Very, very sadly, during this pandemic, the only national story to break through was, of course, Black Lives Matter. And part of the response from the government was that structural racism doesn't exist. Because in effect, we're talking about 14% of the population, which is a minority. We need people to care, to know, to probe beyond minority groups. How hopeful are you that that data, that research, that effort will be undertaken?
Well, it's interesting that it was the George Floyd murder, devastatingly, that really turned the narrative around here. So I'll give you an example here. Just before that, I wrote an essay for The Lancet on race and health and why it was inappropriate to look to genetic factors to explain the racial disparities in health we're seeing. I should add here, race is a social construct. It is not a genetic construct. There are no black genes, there are no white genes, there are no genes that exist in all the members of one race and not another. You know, it's kind of pointless to try and explain health in those kind of racial genetic terms. But I wrote this essay for The Lancet, and I didn't say anything that wasn't in the literature already. And yet essays, which are not usually peer reviewed, in my case was peer reviewed twice. So it went through 2 layers of peer review because the editors were so reluctant, I assume, to accept what I was writing. And there was real pushback from doctors. I had doctors, dentists emailing me saying, is there a higher genetic risk for non-white people? Can I go back to work because I'm an Asian dentist or an Asian doctor and I'm scared? And when the George Floyd murder happened, everything changed. Suddenly, I was getting emails from doctors saying, you're absolutely right. You were absolutely right in what you wrote in the Lancet. Yes, we can't be looking at genetic factors to explain, or innate factors to explain the differences that we see. We do need to have more data on the social determinants of health. And the Lancet themselves invited me to sit on their COVID-19 commission. So I'm part of one of their working groups now. And that for me shows that politics changes everything, even the way that we think about science and health. We didn't have more data in September than we did in April about the racial disparities around this. We didn't have more genetic data. What we did have was a big political shift. And in that sense, I am hopeful, because now, because of the Black Lives Matter movement, maybe we will start to look in the places we should have been looking all along.
Thank you very much, Angela. Jamie, are you there?
I am, David. Thanks very much.
Great. So Jamie is a human rights and discrimination specialist here at Doughty Street and the head of the Chambers Community Care and Health team. Over to you.
David, thanks very much. And thanks to all the other speakers before me. I'm very privileged to have heard your talks and been very touched by them. I'm just going to add a few comments about sort of some legal insight. I'm not going to be able to cover all the legal possibilities. You won't be surprised to hear that, but I just want to say a couple of things. I'm going to treat the issue here as being racism. The public health issue here is racism, and by that I mean, just as Angela has explained, the social phenomenon of racism, not something which is based on some genetic interpretation of a social construct, as has been attempted by some, but I think is slowly kind of receding as a plausible explanation for what we're seeing. And I partly say that because, of course, none of this really should be surprising at all. The fact that there are inequalities in health are well known, indeed have been legislated for a very considerable period of time. And we all have our own anecdotes. I mean, I remember very early on in the first wave going to an Apple store to have a repair done. And, entirely unsurprisingly, the Apple store had hired a team of security staff at the front of the shop to make sure people came in an orderly fashion. 99% of them were Black. Then once you get into the store, the ratio is almost diametrically reversed for the staff who are working indoors. There were a few Black faces, but essentially it was mostly white staff. And then, of course, there were the customers who were almost exclusively white. And it did seem to me that we saw there kind of three elements of racism at once. The structural one, which resulted in the distribution of the jobs, the institutional one. You had the biggest company in the world demonstrating that form of kind of structural racism that was completely overt. And then the interpersonal one, in the sense that, it was no coincidence that the staff who were there to try and intimidate people and under the guise of provide security, prevent people from coming in, were all Black, because it was feeding into all sorts of prejudices. And it was just so stark. And I think that that's what we're seeing in many other respects in this context. These are things which are completely predictable and stark, but thank God for once there is some light being shone upon them. And I think it's quite useful just to look at the question of racism under those three headings, even in the legal context, structural and institutional and interpersonal. And the only comment I was really going to make about, on the structural side, just as Angela in particular has just explained, I mean, this obviously intersects with socioeconomic disadvantage in a very strong way. And indeed, there is evidence that pre-existing inequalities that similarly intersect with socioeconomic disadvantage have also been exacerbated or exposed by the COVID-19 crisis. And certainly disabled people have been actively advocating for their rights in their context. And we're also seeing several challenges being brought on behalf of people alleging sex discrimination in the context of COVID-19, and indeed, it must be said, the government's response to it. Now, what can we do about tackling socioeconomic disadvantage using the law? Well, we're hampered to some extent in that when it comes to discrimination, you can't bring a discrimination challenge on the basis of socioeconomic status, but you can, of course, bring it on the basis of race. And if that's right, and if we can bring challenges on the basis of race, why is there a problem at all? Why can't we just use the law to effectively eliminate the causes of the disproportionate outcomes for Black, Asian, minority, ethnic people? Well, there are lots of answers to that, but one of them is that the law is essentially quite superficial. It struggles to really unpick the structural causes why discrimination occurs. But there are certain things we can try to do. So, for example, it's fairly clear that there's a relationship between the houses that people are living in and the nature of the housing they're living in, the communities they're living in, and as I've already said, that the work they're doing. And so challenges can be brought and have been brought successfully to try and address, for example, income levels by tackling social security reforms to try and ensure that discriminatory impacts are properly recognised by the courts and outlawed where possible. You can bring challenges in the context of the provision of social housing, for example, to ensure that the policies that are enacted do not discriminate against people on the grounds of race or indeed other issues like that. So in a very piecemeal way, you can try to tackle policies or criterion or practices displayed by public authorities largely in that context and try to improve the overall situation. But it would be foolish of me to try and pretend that the law alone can tackle structural discrimination of any form in any kind of absolute way. So that is a war of attrition that has to be based on strong institutions who can bring challenges, fund them, identify them, etc. There's a very closely linked issue to that, though, which is the question of data. And I think it's really notable what Angela in particular and others have said about what data is available. There are, in fact, positive duties on the state in particular to collect the relevant data so that these disparities can properly be identified and mitigation can also be adopted as a consequence. Indeed, the NHS Act itself has in section 1C a duty to reduce the inequalities that exist in health. And you can't do that unless you know what they are and you've collected the data to do it. And the public sector equality duty in section 149 of the Equality Act does something similar in the context of discrimination of all forms, including, of course, discrimination on the grounds of race. So there really shouldn't have been any excuse for the slow uptake by government to start recording and identifying the data, in particular in relation to ethnic disparities in the context of COVID-19. But it took a public clamour and the media and certain well-known people to press the government to do that. So we're lagging behind in terms of the data, but without the data, it's very difficult to construct the challenges to start to identify the causes, or at least the factors which are exacerbating the structural and other symptoms, if you like, of racism in society and how that's panning out in the context of the pandemic. So we need to be alive to those duties and we need to enforce them wherever we can to try and make sure the proper data is being collected. For example, it's only quite recently that the ethnic identity of people is being recorded on death certificates. These are improvements that can be achieved, but we need to make sure that we identify them and litigate them where possible. I think there is a point perhaps to be made in that context about the extent to which this form of racism based on race, is being properly litigated. As I already said, the disabled rights community has done a very good job at bringing challenges, for example, to tackle the government's response to COVID-19 economically in terms of the shape of the job retention schemes, the self-employment schemes, the benefits that are available. Also in the context of the guidance which is given about things like face masks, etc. One has to ask whether or not there is more scope for challenges to be brought on the basis of identifying where the guidance is insufficiently sensitive to issues of race. And as Dr. Darsan pointed out, this one-size-fits-all approach does an injustice to the sensitivities that are there and need to be highlighted. And what I can say with absolute confidence is don't rely on the government to spot all of these things. They won't do it. Some of this is effectively sort of low-hanging fruit. It's some quite straightforward things that could be changed quite quickly. But again, don't rely on the government to do it. We need to bring challenges. So I would really positively encourage both the panel members and others who think that they can identify some of these things, and we're going to hear more specifics from Baroness Lawrence in due course, to consult with lawyers and see whether or not even sometimes a letter to the government saying, well, why haven't you thought about this? Why doesn't the guidance properly incorporate this? Why does your job retention scheme not properly respond to one factor or other, which we can demonstrate has adverse consequences for people of colour? Then we should be doing that. So the structural racism problem is a big one, but there are some things we can do. The institutional racism issue is also one that can be addressed. It's not a concept that's recognised in the law, but public authorities and private bodies that provide goods and services have to comply with the law as it exists in relation to discrimination. So that goes all the way from the NHS as an institution to, for example, Apple. There are certain duties on these organisations to ensure that they act in a way which is non-discriminatory. What's sort of missing, however, or not completely missing, but isn't much used, is positive duties to try and introduce change. Now, we don't have the sorts of positive duties that exist in some other countries, for example, in America, but we do have the powers, at least available, at least in the employment context and in other contexts, to take what's known as positive action. So if it can be demonstrated to the satisfaction of an employer or a public body that certain groups are experiencing a disadvantage, then so long as any steps taken are reasonable, it is open to those bodies to undertake steps which are likely to eliminate that disadvantage. So, for example, in the context of employment practices, where you've got a tie or a break-even situation, then it's permissible for employers to pursue some policy in relation to changing the demographic of their workforce. We've seen it in the context of provision of public services. For example, in the first case of its kind, recently the Supreme Court upheld a housing association which had made special dispensation for Orthodox Jews because it was clear they were experiencing socioeconomic disadvantage. So there are duties available to institutions which could help them try to improve their response, try to make them more sensitive to the particular issues that certain groups experience, and indeed, again, as Dr. Darsan said, to try and evolve from a one glove fits all to a more tailored approach. Then finally, of course, on the interpersonal side, what's commonly known as direct discrimination. Many people think of this as the only form of discrimination which is outlawed, which is very much not the case. But the other misconception about direct discrimination a lot of the time is people understand it has to be overt, it has to be conscious, it has to be deliberate, and it doesn't in fact have to be that. Very much is often about unconscious bias in the context of decision-making being treated as direct discrimination. And there's an important feature of the law in that regard. The burden of proof provisions require courts to make findings of discrimination in circumstances where a difference in treatment can be demonstrated and there doesn't appear to be any other plausible explanation for it. So even in the absence of any overt admission of racism or any other form of discrimination, the courts can make a finding that such racism has occurred. And of course, that's important because with few exceptions, it's not often that people are willing to own their own racism or even admit that they may be susceptible to racism in their work or indeed their personal lives. So
Jamie, I'm gonna
I was just going to finish. Sorry, I'm conscious. I've just gone over. I was just going to say, that was my contribution, and I'm sorry I don't have a kind of silver bullet, but there are things we can do incrementally if we've got the data and we focus on the issues at hand.
I'm conscious. We started about 10 minutes later than past, so I'm going to go, if I may, to 7:10. But I'm not going to. I have got a question for you, Jamie, but I think we'll do that when we come back. Baroness Lawrence, who needs no introduction, so much work over so many years, coming out of painful injustice. And we are very grateful for the intervention and the first report really in this area that Baroness Lawrence was able to lead. And I'm very grateful that Doreen is a great friend and colleague.
Thank you, David, and thank you all for being here this evening and listening to the stories. One of the things for me when I was asked to do the review, when Keir Starmer became leader of the Labour Party, for me, I felt that the party needed to have a race advisor, because I believe that over the years, the Labour Party relies so much on around the Black and ethnic minority during the election time, but they don't have a voice, as much voice as they should, I believe, in the party. So that was my thing of asking Keir to be the race advisor. And at the same time of that is when the pandemic was beginning to raise its head. So I was asked to conduct a review, and this was with Marsha Dikova from the Women, she's
Women Inequality.
I said, thank you, David. And so it was a strange time. I think this lockdown, well, the first lockdown, if you sort of remember, people usually just use like FaceTime when they sort of speaking to their family and their friends. And now here we are doing Zooms, Teams, and this is so unusual of how you conduct meetings across the country. So our review was conducted throughout the spring and summer. And for me, it was important to speak to members of the community, to hear their personal experience on the impact of the virus on their lives. I heard some distressing stories of families losing their loved ones. I think one of them for me was when I remember the family died, and they had various people come into their homes in order to sort of remove the body, and everybody came and said, oh, we can't do this because we haven't got our protective gear on. And so can you imagine the distress of the family having to wait and listen to everybody's telling them what and what they can't do because of the PPE that they don't have. And so as has been mentioned at the beginning, the issue around PPE and the heightened death rate of Black and Asian minority. The PPE continued to be a concern all the way through the first lockdown of the pandemic. Those who felt that they were forced to work in an environment that they did not feel safe, this sort of fell on deaf ears of their concerns. None of this was addressed. And there was calls for people to stay at home to protect the NHS, and those who couldn't stay at home had no financial support. People on low income were forced to work in order to support their families. People were self-employed. There was no resource of public funds. I wanted to hear the voices, as I said, of people. It is important for us to have this credible information. And for me, one of the voices that I heard was when one of the medical staff said, I didn't go to work to die. Now that is quite heartening to hear when you're listening to people from the profession telling you of their experience. At the end of the review, we had 18 recommendations. And there was no one single factor that we could say was the cause of death within the Black and Asian minority group. There was a combination. And I think one of the real things was about the structural inequality that existed for decades. Our recommendations raised from calling for a race audit, ensuring that all policies and programs helps to tackle the structural inequality, to introduce a mandatory ethnicity, the pay gap reporting, tackling health inequality. As you know, inequality in mental health, and there was a problem for a long time in the ethnic minority community. And with COVID, this became a bigger issue and still yet to be addressed. Many of the support help groups find it difficult with people suffering. These community groups try their best to help, but a lot of falling through the gap because of the lack of funding to help. The report was well received by the BMA. The chair of the BMA, Dr. Chanan, if I'm not pronouncing that correctly, talked about the impact of the report and his experience. The BMA was one of the professionals who engaged with the review with their colleagues. Any development since the report, things that you would have included in the report were to be published, perhaps relating to the vaccine. The trials, one of the things that the trials was not published. So I believe not a lot of people of the ethnic group were took part. On the roles of the vaccine and who is eligible, the question I asked is, when the testing were happening, how many of the ethnic minority was involved in the trial, and what were the reaction of those who took part? We now know that people from the Black community have concerns and have indicated in large numbers that they will not be taking the vaccine. How is the government going to reassure the community that the vaccine is safe and for them to come forward when their time comes? It would be helpful for the government to publish data to reassure the Black community on the vaccine rollout. At the start of the pandemic in 2020, it was revealed that the Black and ethnic minority would understandably have a greater fear of the virus. So, as report has indicated, an alarming high number of deaths in their community. The review contacted health and social care workers, and listening to their stories were largely the same. The PPE not being listened to when they raise concern. They're feeling vulnerable and still wanting to help their patient and not being tested. Local council members felt the lack of communication from the central government. Daily news from the government say that they put a protective arm around the nursing home. During this time, nursing home in some cases reporting a shortage of PPE, a shortage of staff, and residents are dying at an alarming rate. One voice, as I said, I've talked about, who said that they did not go to work to die. This level of concern that is out in the Black community. If the community feels that they are shut out from decision-making process, it is understandable that their reaction and result in a lack of engagement. The Black and ethnic minority community have felt that they are living and continue to live in an hostile environment. Since the publication of the review, I have not been informed whether the government intended to address any of the recommendations we made that were brought to their attention. What can be done to address the healthcare inequality? The government needs to provide the resources that is needed that starts to address decades of poor housing, education, health in the Black and ethnic minority. I understand when we talk about housing, and at the start of the pandemic, we would hear around the doctors and professionals who were dying. And as we heard earlier on, that doesn't address the issue of overcrowding housing. As we know, healthcare work doctors who were dying at the rate did not live in overcrowded housing. So as we sort of move forward, what the review was trying to address and still trying to address is the structural racism that existed in the healthcare for decades, and how is the government's policies going to change in order to adapt and help to address those issues. As I started off by saying, for me, it was important to listen to voices of people, because I think that's the only way that would help to inform us as to how the death rate was affecting individuals. I have spent the last, you could say, 27 years struggling around racism after the death of my son, and the pandemic and the structural racism that existed then. Not the pandemic, the structural racism that exists then, where the pandemic has highlighted that within our community, and is how is the government is going to address that. And as we move forward, I mean, so we can see in the second and third lockdown that the pandemic is even worse than it's before. And the difference is at this point, where in the first lockdown, and as it moved forward, you'd have reports of how many people within the Black and ethnic minority was dying. Now you do not hear any of that now. So reporting of the deaths and the stats does not help us now to know the effect of the pandemic as the time move on. So that will be something worth having the government within their stats showing the impact as the pandemic continues to have on the Black and ethnic minority. So I feel that being given the opportunity to speak to individuals, speak to professionals, speak to council members who are coping on a day-to-day basis on the pandemic was something for me. I was humbled to be able to take on the role, to able to help to assist in highlighting the voices of people from our community.
Thank you very much, Baroness Lawrence. Again, I'm not going to come specifically to questions because I want to open it up in the time we've got available. We'll try and go to about 15:15 so we can get some questions in. I've just looked at the questions and I'm going to target them. So there are a set of questions around the South Asian community, and I wonder if Intisar, Angela and Sunil might come back on this. It's really around predisposition to not wanting to be a nuisance. It's around extended families. I mean, this is true also in Black communities, frankly. And I wondered if you just wanted to address that. There's another set of questions around whether there should be a public inquiry into the disproportionate death rate of Black, Asian and minority ethnic people. Now, of course, there should be an inquiry into the overall, so maybe this has got to be a huge and important dimension of that inquiry. How do the families that are grieving get that support, and what are their calls? And Intisar, you may have a view on that, and certainly Jamie, you would have a view, I suspect, on whether there should be an inquiry. You may indeed be involved representing families if there is such an inquiry. Angela, also there's questions about the efficacy and the importance of vitamin D, and it sort of bounced up as an issue. There was some indication it was an issue, and then it sort of disappeared. Black, Asian and minority ethnic communities were sort of left to make up their own mind as to what they wanted to do. Some get shouted down if vitamin D is mentioned. Others feel very strongly that vitamin D deficiency is important and can help. And I just wondered if you had any of the latest on that. I'll start with Intisar and just ask you to be a little bit brief so that we can get background.
Of course. So on the issue of one of the questions raised about how South Asians, especially the elder generation, actually I think all minority communities, especially the elder generation, feel that they might be a nuisance if they, for example, feel symptoms or, are suffering in any way due to COVID-19. I think it's so important that we remind everyone, but especially the elder generation within minority communities, that they have just as much of a right to healthcare as everyone else that is living in our country. They have just as much of a right to be here, to have access to all of our services, to everything as everyone else does. So the second that that someone in that community is, you know, not feeling well, feeling symptoms, they should feel confident and they should feel that they have the right to ask for help, to go to see a doctor, or maybe not necessarily see straight away in the situation, but to have access to someone that can help them. I think it is definitely a big issue among, I think, all minority communities, that it's, how do I explain it? It's kind of like they've come to this country, but they don't want to be a burden or something like that, kind of. They don't want to add any more stress onto an unfortunately overstressed NHS. But I think it is so important that we emphasize that, especially the older generation, they have a right to be treated, to have the help that they deserve. And yeah, I think that's the crux of the issue. I think you're muted, Mr. Lamy, sorry.
Sunil. Thank you, Insta.
Yeah, no, I was just going to say that, I mean, some of it may be learned from previous experiences with contact with the health system. So that may then influence their health-seeking behaviour going forward. And I mean, I think it's hard to make generalizations in terms of why people are, you know, not seeking help when they should, and that there may be an element of people trying to minimize their own symptoms and just being, you know, try and stay under the radar. I mean, there is you know, people who come to this country, again, not wanting to impact an overly already overburdened system. But I think it's within the gift of medical and healthcare professionals to change that narrative. I think we can change that narrative to say, look, whatever symptoms you have, if you're concerned by them, attend and we will look at them. I think there is a issue with medical training in terms of being able to make sense of symptoms, in terms of how different cultures describe different symptoms, and about learning about how illnesses present in different ethnicities, I think is another big piece of work that needs to happen.
Sunil, should these communities have been prioritised for the vaccine? Would that have solved some of the problem of hesitancy if they'd actually heard the government say, we see you, we hear you, we think you should be prioritised, please come forward?
I think that's why I was, what I'd like to see going forward after the pandemic, and even while we're in the throes of it, is an outcomes-based approach, so that we know that being Black or Asian or minority ethnic is a vulnerability in relation to COVID. Therefore, that should then make those people a priority group. Now, I don't know politically how one then puts that narrative into the public domain, because again, there will be, I'm sure, a lot of pushback to that. But I think in terms of within healthcare, once we start getting data about relative death rates for different conditions amongst different ethnicities, then actually we need to know that particular ethnicities have particular vulnerabilities when it comes to these types of presentations. And that's where we as healthcare professionals need to pay particular attention.
Thank you. Angela.
Well, I'll talk about vitamin D in a sec. I know we don't have much time, but I just want to say I would very much hesitate before saying we should prioritize ethnic minorities for having vaccines, because there are so many different factors, like I said, that make an individual more vulnerable. And ethnicity is not some biological thing within Black or Asian people that makes us more susceptible. The reason that the vaccine rollout has been the way it is because we know older people are many more times more likely to die than everybody else. And so that makes perfect sense. That's a biological difference, you know, it's an innate difference. And we know that frontline workers are more likely to be exposed. So that's, again, a biological risk that they face because of exposure. That the same things aren't true for ethnic minorities. Exposure and risk comes from a multitude of factors. I would certainly not want to be at the front of the queue knowing that I'm well off, I'm healthy, I'm young, and I'm quite capable of isolating at home. I don't, you know, I'm not at increased risk compared to many other groups of people. So we need to be more careful than this, I think, just thoughtful and nuanced in the way that we think about individual risk rather than group risk. All these different factors coincide in one individual, and you know, that's the level at which I think we need to understand this. And regarding vitamin D, I think the jury's a little bit out on vitamin D at the moment. There's no doubt, obviously, it's linked to immunity, although I've been taking vitamin D supplements for years and it didn't stop me from catching COVID last year. So I'm a little bit hesitant before seeing it as a panacea.
But you're still here, Angela.
I'm still here. Yeah. But I would say that I think that that narrative around vitamin D at the time that it came spoke a little bit to our desire to want to see one simple explanation for the statistics. And again, as Baroness Lawrence was saying, there is no one answer here. It is not because we are all deficient in vitamin D. It is so many different things. And yeah, we just, again, we need to kind of have a nuanced understanding of what's going on.
Jamie.
Public inquiries. I mean, they've become more fashionable of late, and certainly we need a public inquiry in relation to decision making around COVID, because I think everybody can see that there's room for improvement there, and who knows when the next pandemic is around the corner. The only issue, or note of caution I would raise about this, is that if we hope that an inquiry will provide the solutions to structural racism, then that would be a bit ambitious and unrealistic. But that wouldn't be to detract from the fact that having a public inquiry which recorded the relationship between structural racism and these outcomes could be very important in terms of marking a line in the sand. And so for that reason, I would be in favour.
Thank you. And Baroness Lawrence.
Around structural racism, this is not something new. And to look into, I always find that individual, it depends on who they are, if they are willing at times to speak up around racism that's affecting them. And hence why should they be the ones who have to be always drawing it to your attention? You know, it's there for all to see. So, you know, for an inquiry to happen, I think it'd be a good idea, because I feel that at the start of the pandemic, people know around the protection, and for people within working in the healthcare, they shouldn't have to be saying that we need protection. It should be something that's given to all. And for those who speak out about it, they were either made to feel as if they had no right to do that. And even though they want to support their patient, but they do have difficulty in challenging the powers to make sure that they give the adequate protection that they need. So I always find all these things very difficult, because it seems as if we are the ones that always have to be justifying, asking questions, making sure that our rights are existing. So there's those who are in the position to make sure that we have all these things that we need to have in order to protect our workers and the patients. You know, to me, I think that's just standard.
Thank you very much. Just to go back to you, there's a question at the end here about what action white and white allies can do to promote the understanding of these disparities. There's another question about how hard it still is for people to navigate the NHS. And I wondered if others might want to come in on what more needs to happen in relation to that. And then I suppose, what are we going to do about vaccine hesitancy? Because in the end, more people will die unnecessarily, is the truth. So what needs to be done in relation to vaccine hesitancy that's not happening?
Who are you looking
Well,
to?
I thought you might come back on that first question, but if you want to think.
Well, no, I think that's one of the questions I asked in the chamber about the trials, because I think unless the community see that within the trials that the Black and ethnic and minority were part of the trials, and so that they can they can see for themselves and demonstrate that the vaccine is safe. Because people are always questioning, because I think if you go back centuries or generations back, where certain vaccinations are tried on certain ethnic minority.
Right, yeah.
And so that's where the concerns are coming from. So
my understanding is that the trials, there were trials in South Africa on people of African descent, certainly. There were trials in Brazil. There's a lot, certainly people of African descent. So those are the two areas. I do not know, I cannot speak for those of South Asian background. Maybe Angela knows the answer to that.
and what was the result? How many, were anybody have side effects or anything?
I don't know the numbers. I don't know the numbers, but they took part in the trials to get the efficacy.
Yeah, those are the information that people would want to know.
Yeah. Can I bring Angela? Anyone else who wants to come in on those sets of questions? Angela.
I'm happy to respond. I do think the trials around COVID have been a bit more diverse than maybe trials have been in the past. We also need to bear in mind that there's no huge biological differences that would mean that even if it were tested only in one population, it wouldn't work in any other populations. And that's true of all drugs. So people shouldn't worry on that count. I wonder, I do a lot of work around scientific misinformation, and I do know that in, for example, WhatsApp groups among Indian communities in my own family, I've seen vaccine disinformation being shared, concerns about vaccines, these false myths.
Thank you for mentioning that. We haven't mentioned that before. A lot of misinformation, and some of it deliberately targeted at Black, Asian and minority ethnic communities. Yeah,
and social media companies have been very bad on this, I think, historically. I hope the new online harms bill will take into account scientific misinformation, health misinformation when it comes in. But the sad thing is this pandemic came at a time when we don't have the internet regulation that we need.
Jamie, do you want to come back in?
No, I have nothing to add to those answers. Thanks.
Sunil?
No, I'm fine. I think in terms of the only other thing is in terms of communities that are, even though I don't really, I'm not a great fan of the term vaccine hesitancy, but in terms of those communities, I think, for me, it's about trust in the health service and what we can do to engender that trust should then help people to come forward. I know that there is lots of outreach into faith communities at the moment and to try and get increases in uptake in the vaccine. But I think, again, as Angela said, a lot of these inequalities, as well as being societal, I think my sense is that, it is within health systems as well, and we need to get rid of those biases so that everyone does consider that race is a construct and that, actually look at the other determinants of health and look everyone through the lens of equity.
I guess that in terms of whatever you want to call it, vaccine hesitancy, one of the challenges is that actually even amongst NHS workers who obviously are within a priority group, there has been a lower uptake amongst Black, Asian and minority ethnic people. That demonstrates the scale of the challenge. And certainly my understanding is in relation to the Black community, that it's not just older Black people, it's right across the age group. So the likelihood is that this any campaign has got to be sustained, because the issue will continue for much of the remaining year. And what concerns me is, of course, to get the herd immunity, but again, I'm happy for you or Angela to tell me I'm wrong, we do need the 14% Black, Asian and minority to participate and to take the vaccine. So I think it is a very real issue, these trust and mistrust issues and the misinformation. You know, what I found in amongst my relatives, particularly older Black relatives, is that many of them were on WhatsApp for the first time, because it's a means of communicating with their children, their grandchildren, because they can't see them. And they're consuming the misinformation like they would consume the television. You know, you get these little videos and you're pressing play on it, and the video is coming from a family relative. Often it's very humorous, and it's being digested over a period of time, which obviously feeds the mistrust. And some of this is about the way in which, for minority communities, the mainstream isn't speaking to you, so you find your channels in other places, basically. So it comes back to these issues of sort of structural discrimination, it seems to me.
I'd agree, David, and as Intisar mentioned, having videos and recordings in different languages that speaks to individual communities is, I think, the way to go. And up until now, it has so much been just a very limited approach that needs to speak to a certain section of people, but there is always a subsection of people who are not going to engage with that.
Angela, did I see you wanted to come back in?
Yeah, I would agree that there are different ways in which misinformation spreads, and I think the power of the WhatsApp or the Facebook science group and the way that science spreads there is that we trust what our friends share with us, what our family share with us, more than we trust what we're reading on the BBC News website or the New York Times website, sadly, because that's just our psychology. It's natural to do it that way. And the problem is not, you know, our personal failure, although of course we do have to take responsibility for what we share. I think it lies also with these platforms. I left Twitter. I quit Twitter last year. I quit Facebook long before that. Largely because of the abuse I was getting, but also because I do not trust these platforms to care about this stuff enough. And I think if we really care about justice on this front, health justice, then this is one big place we should be looking around this new online harms bill that the government is bringing in. Lobby your MP and keep your eye on it. Try and make sure that anti-vax information, anti-health information, scientific misinformation is part of the government's plans.
I wanted to add to Angela's point, actually, about social media literally being a breeding ground for disinformation and conspiracy theories. Is actually terrifying to a point, because I'll be on Twitter, I'll see one tweet about, you know, how vaccines aren't what you think they are. They're actually microchips or something, things like that, things that sound ridiculous. But a lot of people actually believe that. Or things like, you know, the vaccines won't help you, or that masks have no effect on how COVID can spread. And when one person tweets that and someone else sees that and wants to believe it, they then retweet it, and then that gets shared with more people. And when there's not enough regulation on social media, that spreads. That's how disinformation spreads everywhere. That's how it becomes a breeding ground for essentially a lower vaccine uptake. And I think those things need to be addressed, perhaps on a governmental level, with more intervention in social media regulation. And I think another issue is that the idea that you need to have 2 doses of the vaccine isn't being stressed enough. I think, I'm not sure if that's been mentioned yet, but I think a lot of people are perceiving that if you have 1 dose of the vaccine, that's enough, you're vaccinated. And I think that's the idea that's being spread around. But as it is, I don't think with one dose that you're protected. I think that is what the information is right now. I'm not sure if there's been an update, but I'm pretty sure that 1 dose isn't sufficient enough to protect you from the virus. But I think, yeah, basically we need more intervention in regulating media, the spreading of disinformation, and perhaps maybe sanctioning intentional spreading of misinformation so that it doesn't actually occur anymore.
Thank you. So, Jamie, were you going to come back in there?
Well, only as a sort of point of information that the Office for National Statistics attributes the closing in the gap between black men and white men that Sani mentioned in her opening remarks, interestingly, to better health campaigning and basically outreach work. Now, I'm in no position to scrutinise that, but it's a sort of example of what I mentioned earlier about sort of low-hanging fruit and quite obvious things that might potentially be done that we can't always rely on the government to do, that might change the outcomes here. So, you know, it seems consistent with what's been said by other panelists on this issue of information in relation to vaccines, but more generally, it seems to be a relevant consideration in the context of disproportionate impact.
Jamie, I just want to put one point to you. Angela, you might come back in as well on this, which is, of course, some of the Q&A is saying, look, also, and I've heard this from the black community, I'm really clear, please take the vaccine, save lives. This is important. We've already got a disproportionate death rate. Please take the vaccine. I'm really clear on that as a public servant, and that's the message that I want to be absolutely clear on. But of course, others raise a freedom of choice issue, that they are entitled to look at the information. And one of the things you hear from Black, Asian and minority ethnic communities is not necessarily, no, I'm not taking the vaccine. It's not yet. And so where do we balance the free? I want to see the others take it first, and then I'll come back towards the end of the year. And I'm happy to shield until that point. See, cousin David, ring me up in August. We can talk, sort of thing. But that freedom of choice point, that on the basis of the information I know, don't call me stupid. I know about racism. I experience racism. I'm entitled to say, no, thank you, I'm going to wait. How do we balance that in a context in which we have a national health service and a national emergency?
Well, the prerequisite is that you're allowing people to make informed decisions. That's the first and most important thing. So I think we've already covered some of that ground. The second one is, you would need to assess whether or not overriding people's free will was likely to produce beneficial outcomes more generally. And I think, we've seen that in relation to some other vaccinations more generally that are required to be taken by children. It's a different ballgame for adults. And of course, we don't make the flu vaccine mandatory for adults, for example. I think it'd be a pretty brave step to go down that road. And I think you probably want to look at it as a last resort because of the adverse consequences, not only for the administration of trying to govern a piece of law like that, but what it would obviously do to spike the anti-vaxxers and the conspiracy theorists who would, that would feed right into their worldview, I would have thought. So we'd be wary of that.
Angela?
Well, I can understand people's reticence because we are in a real-time situation when it comes to science. More science is coming, and as it comes, more data is coming. As it comes, our confidence in the vaccine increases or decreases depending on what the data says. So I can get that. So I'm just going to mention in my own family, my mum has just had her vaccine. My dad, who is at quite high risk, he's in his 70s, has went to get the jab and then changed his mind and came home and hasn't had it yet. And the reason for that is he's quite nervous. He has a lot of allergies, including a penicillin allergy, which is very severe. And many years ago, I remember when I was young, a doctor, even though it says in his medical notes that he has a penicillin allergy, gave him a drug containing penicillin. He had a terrible reaction and nearly died. And that has stuck with him. So I understand. I get it. There are lots of different individual reasons that we have for being nervous and not wanting to take on that personal risk involved in trying out something which is very new. But, at some point we do have to say, when it's not just about you, it's also about everybody else, because we need everybody to be protected by this. And we have to trust the scientists a bit, as hard as that is to do at the moment, given, like I said, the situation that we're in. But I understand how people feel, and we have to engage with those fears, and rather than deride them or mock them or assume that some kind of generalized campaign is going to overcome them.
Thank you so much. That's a very nice way, I think, to end, actually, sort of recognizing what's out there and legitimate reasons why it might be out there, notwithstanding the sort of broad point of view on the forum. I think I've really enjoyed that hour and a half or so of debate and discussion. I hope that all the audience many of you have stayed past 7 o'clock to hear a bit more. So very, very grateful. I'll hand back to you, Srini.
Thank you so much. I just wanted to say again, thank you very much. That has been a very interesting and enjoyable hour and a half. I just wanted to, before we close down, to say to people that the event has been recorded and the recording will be available on our YouTube channel shortly. So if you want to share it or watch it again, it'll be available to you there. So I just want to say with those words, thank you so much to David Lammy for chairing this superbly, and for everybody else for their really insightful input and the good questions we've had too. Thank you very much for all the participants for joining in. So with that, I think we just say good night to all the participants and to everybody. Thank you very much.
Thanks so much. It's been great.
Thanks.
Thank you to all the panelists, particularly. Thank you.
Yes, and thank you so much.
Thank you, Ashwini.
And
Thank you
for taking the time to come and share your thoughts. Fantastic.